This episode of EMS One-Stop is brought to you by Lexapol, the experts in policy, training, wellness support and grants assistance for first responders and government leaders. To learn more, visit lexapol.com. That's lexipol.com.
Well, I think a really important part of research that a lot of people forget to do is just to do a really thorough background investigation and then kind of start from the bottom and work your way up. And it's not just about collecting the data to look at the effectiveness of an intervention, right? It's also to look at the process of an intervention because, as you say, who's paying for this? How are we going to implement this? Is it even possible to adopt or sustain? And all of those questions are really important to ask.
Hello and welcome back to another edition of EMS One-Stop. I'm your host, Rob Lawrence, and I'm back from the summer outing to the United Kingdom. Spoiler alert, no, I'm not. I'm actually still sitting in the United Kingdom. Here's the power of Zoom. But we're back for the second half of the year, and we're going to go straight to South Carolina, to Prisma Health, and to talk about Prisma Health's mobile integrated healthcare programs that they're running. And the reason that I've gone down to South Carolina today is because they're running programs that you really need to hear about. And so let's bring in our guests, and we've got a team from Prisma. So Luke, first of all, welcome, and please introduce yourself.
Hey, thank you. I appreciate the opportunity. So my name is Luke Estes. I manage mobile integrated healthcare for Prisma Health. That's headquartered in Greenville, South Carolina, but we have a swath of about 10 to 12 counties that our enterprise operates in.
Great. And before we hand on to Mirinda, of course, we met a few months ago because you were a recipient. In fact, the whole system was a recipient of an AIM High Academy of International Mobile Healthcare Integration Health Award for the great work that you're doing. And again, all the links to the awards and the programs will be in the show notes. So great to see you again, Luke. Great to see you again, Mirinda.
Yeah. So I'm Mirinda Gormley. I am the epidemiologist serving as a biostatistician in the Department of Emergency Medicine at Prisma Health. I do a lot of work with the Mobile Integrated Healthcare Program on several of their different activities, and I do a lot of the program evaluations and research for those activities.
Wes?
My name is Wes Wampler. I am a community paramedic with Prisma Health. I work specifically with the Addiction Medicine Center. With their inpatient, outpatient patients. I also work with our infectious disease docs for our HCV program.
And full disclosure, Wes, Mirinda, and I worked together in Richmond back in the day. So it
was the day.
Parker.
Good afternoon, good morning. My name is Parker. I'm a community paramedic with Prisma Health. I primarily serve as what most folks would consider a standard community paramedic now, but I've touched on the ETS program, which we'll talk about some, I suspect, as well as served as research coordinator for the buprenorphine pilot that we did here in the upstate.
Fantastic. So, Luke, first of all, some great work going on. So just start by giving us an overview of what you're up to there.
Yeah, so thank you for the award. It's always good to see the team get recognized for all the work they do, because they really do a lot of hard work, and I'm excited when they get recognized for it. But so Prisma Health went to a value-based healthcare system or value-based healthcare approximately 3 to 4 years ago, where outcomes became something that were stressed, right? And so they developed this mobile integrated healthcare program. They brought in a team. Actually, Wes and Scott Gossel were here before I was, and they were kind of laying the foundation of what can community paramedics do to help tackle some of the problems that a healthcare system sees. And so we've developed traditional community paramedic programs that have social determinants of health. We've developed the ETS program, which is emergency technicians in skilled nursing homes. So that program was designed around high frequency but low acuity problems that happen in nursing homes, and sending a community paramedic versus an ambulance. So reduction of EMS, reduction of ED, and overall patient satisfaction. And then from there, we really just grew into what can we help do? And that was the work that Dr. Gormley and Wes are using in infectious disease, in addiction medicine, how do we help with our PACE participants that are part of the program? So we have a PACE participant program that helps just kind of take care of the high frequency, low acuity stuff that come from PACE patients or PACE participants. And then it just kind of grew, and it's been an amazing ride, and excited about where our other programs are going.
So, for those that are listening to this show, will know that I am a massive proponent and fan of public health and all things data. And this really comes back down to Dr. Mirinda Gormley, of course. Take us back into your backstory, because you have been doing this in some fairly lofty places in your past career.
So I got my Master's of Science in Public Health at Tulane. And while I was there, I was a volunteer in the Vigor program with New Orleans EMS. And it really got me very interested in EMS and something that I knew that I wanted to pursue. So I applied for a fellowship at the National Highway Traffic Safety Administration, or the NHTSA Office of EMS. And I was there for about 3 years. And then I came down to Richmond, the Richmond Ambulance Authority, where I actually got my boots on the ground for approximately a year before I started my PhD in epidemiology. So working with the populations that we worked with in Richmond, the populations that I saw up in the Northern Virginia area when I was a volunteer EMT and paramedic up there, it really brought home to me just how important it was to address opioid use disorder, because of the number of people that we saw, not only that had the overdoses, but the family members that were there with them affected by it. And as you know, most of the time after we see a patient following an opioid overdose, we have these family members begging us, please take them to the hospital, please make them go, make them get treatment. But our relationship with the patient ends. After we give them naloxone and they refuse service, or after we drop them off at the hospital, we don't know what happens to them. Sometimes we respond again, and it's a less fortunate outcome. So it just brought home to me, like, what can we do? Well, how can I extend this relationship? How can I use my experience being in the homes with these families, with these patients, to connect them to treatment, to be a part of the solution? And that's why community paramedicine to me is so important, because you have community paramedics that go out into the homes and can extend that relationship with the patient and spend more time with them. And so that's why that program is so important to me, and pretty much why it's my primary area of research now.
So pre-hospital is data rich. Sometimes we don't use it to good effect. Certainly, again, always had a connection with public health. Always had an intern in the summer, actually. And here's our data. Sign the HIB agreement. Have at it. Come up with some solutions for us. Obviously, you've been drilling down into the data set and everything you've got going on there. And obviously, you have been instrumental in driving this forward, in actually creating the evidence to create the programs. So what have you done there in order to, to build the data, the papers, the peer reviews, and obviously then the solutions?
Well, I think a really important part of research that a lot of people forget to do is just to do a really thorough background investigation and then kind of start from the bottom and work your way up. And it's not just about collecting the data to look at the effectiveness of an intervention, right? It's also to look at the process of an intervention, because as you say, who's paying for this? How are we going to implement this? Is it even possible to adopt or sustain? And all of those questions are really important to ask. So we basically started from the ground up. We did a systematic review, or a scoping review rather, looking at all of the buprenorphine programs in the United States. And we built our protocol based on those different programs and the protocols that they had, the inclusion and the exclusion criteria that they used. We got that approved by our state board of EMS to do a pilot project. And then for a year, we had our 911 paramedics giving buprenorphine for individuals that were eligible at the scene of a non-fatal overdose. We have a very high transport rate, a very low refusal rate. So most of these patients did go to the hospital. But after that, we tried to initiate the community paramedic part of that pilot. So we not only had people giving buprenorphine on the trucks after a non-fatal overdose, we also had Wesley following up with them within 24 to 48 hours after that overdose. He would go out, visit if they needed a bridge of buprenorphine before they could get into treatment, then he would provide that. We collected all of the data from that project. We found that even though we have a very small sample size, because we are very rural, which is another reason why our program is very novel, because a lot of people forget about rural EMS. A lot of the other programs are in urban areas, but we have a lot of opioid overdoses here. And so he was able to connect with about 24 people, and of those, 86% of them ended up connecting to treatment. And I mean, like, they had a foot in the door at an appointment within 30 days of the overdose event, which is wonderful. So we did that. And then we noticed that we were having some barriers to care, right? We were having some barriers to individuals providing buprenorphine in the back of the ambulance, which is a case report that paramedic Bales ended up writing for us, and he can explain in further detail. And then based on the findings of his case report, we had paramedic Wampler go out and speak to all of these EMS professionals and ask them, hey, what do you think about initiating buprenorphine, right? And I think that qualitative data, collecting that information from those focus groups, getting everybody's perspectives on how do we feel about this and how can we change your mind was really, really important. And one of the big things that we learned from his study was that we really needed to go out and make sure that everybody was aware that addiction is a disease. Like, you wouldn't just tell somebody, a diabetic, well, I'm not going to give you D10 because you haven't been taking your insulin, you haven't been acting appropriately. But we're very comfortable doing that for individuals that have an overdose, right? But we shouldn't be. It's a disease. And so we should be treating it that way. And that's one of the lectures that we've given. And we have seen people change their minds in the room and say, oh, how can we bring this program to, our county? So that's one of the wonderful things that we've done. Our next step, we have applied for grant funding from the South Carolina Opioid Response Fund. We're hoping to get bigger funding for our program, and then we are going to do an evaluation of the implementation, right? The process. So we're going to do a more thorough evaluation, not only of our staff here, but also the patients, and see how they feel about this program and how it's helped them, or if it's helped them address the barriers that they have to seeking office-based treatment, which is a lot of times why they don't go. So that's what we've done from a research point of view.
So thank you. That so many questions to throw back at you all, but I'm going to go back to Luke. As Wes will remember, I was the guy in the corner office that constantly moaned about who was paying for this. Then I'm sure, Luke, you have an element of that too. But obviously, this is a program that's been, obviously born out of research, identified the need. How was it put together, and how is it sustained in its operation? From an operational question first before we go into the clinical stuff.
Right. Yeah. Well, first, as a leader, passion, right? Mirinda, Wes, Parker, when you see some of your people who have a passion for a certain pathway in EMS, you try to give them the reins and say, you're going to do some good, and we need you to be passionate. And they are passionate. And so that makes it a whole lot easier, right? When we start talking about how do we fund it, because they're out looking for things every day, grants, sponsorships, whatever they can get to help them take their passion to the next step. And as a leader of this organization with them, it's just keeping them their nose to the wheel and going forward, right? Because they'll do it. All I have to say is, what do you need? I'm here to support you. Let's do it.
Okay, what I heard there was a good leader supporting amazing people. So check. Let's go to the guys that are doing the job, Wes and Parker. I mean, take me through a typical day in the life of a community paramedic delivering all the range of services that you're doing. Let's go to you first, Wes.
So I work specifically with the Addiction Medicine Center. So all my activities and everything are geared around addiction medicine and that department. So my typical day starts out, I go with the rounding. We have nurse practitioners that see patients up that are referred for addiction medicine services. So we'll do rounding. We'll talk about all the patients that are up on the floor. And then if there are patients that I can go see immediately, to get them initiated into treatment, or to follow up on social determinants of health that they need, or to help knock down some of the barriers that they may see when they get out of the hospital. If we can set them up to be successful after they leave the hospital, I think that's the best way to get them re-engaged with the hospital. Also, a lot of these patients are kind of distrustful of the medical system, and if we can go up there and just spend some time with them and talk to them about issues that they've been having, some barriers that they see, and then after they're discharged, actually follow up on that and be with them, then I think that's a good way to gain their trust. So Another thing that we've started is initiating HCV treatment or hepatitis C treatment for these individuals. Usually there's a lot of paperwork and everything to get to initiate somebody on these very expensive medications. And there are not a lot of programs that initiate care while the patient's inpatient. So I'll go up and see them. We'll talk about the program, see if they're interested. We'll get make sure all the labs are done, make sure all the paperwork's done. We'll even have a telehealth encounter with their infectious disease physician, get that all lined up by the time they get discharged. Usually the meds, if they're not arriving at the patient's bedside, they'll be arriving at the patient's home by the time they get home. And then I will follow up with them with any other needs that they have, any other barriers that they have, but also I'll get, 4 and 12-week labs. I'll make sure they get their medicines. I'll make sure all the paperwork's submitted. And then that goes the same for patients that are identified through our emergency department that are tested for hepatitis. If they come positive, a lot of these patients, they live out in Oconee, which is, 20 miles, 30 miles away from our main hospital where all the infectious disease docs are, and they don't have money to make it down to the grocery store, much less make it to the hospital to see a patient. They can't get out of work and spend that much time. So I will go out to them, to their house, walk in their home. I'll bring a computer. I'll bring some lab supplies, my monitor, do an assessment. We'll get labs. We'll do a telehealth encounter with our infectious disease doc, and then we'll get medicine sent to their door. At 4 and 12 weeks, again, we'll get follow-up labs, and they never have to leave their home and get treated. And these individuals are individuals that usually they don't they're not highly engaged with the medical system. There's a huge no-show rate for this population, upwards of 60, 70% that don't even come back. And these patients, we're getting them engaged. I think our last numbers that we looked at were in the very, very high 80s, low 90s of percent of those that engage with us. We're getting them cured. And I think that's a huge first step in gaining their trust back and getting them on a healthier lifestyle.
So we are assisting the patient where they need to be in the home. And is it fair to say then they are not going to come back into the system, certainly as emergent patients, sooner than perhaps, the more frequent patients we perhaps in the wider EMS world are used to? So are you, keeping them healthy and happy at home where they want to be, I think.
Yeah, absolutely. And I think the trust thing is a big thing. Usually, these patients are very distrustful of they've had some bad interactions. And if we can gain their trust, then we can cure them of their hepatitis C, and then we can help identify if they have diabetes issues, if they have CHF issues, if they need help applying for Medicaid or food stamps, something like that, then we can if we can gain their trust, there's a lot more that we can kind of weasel our way into to help them solve and get them on a healthier trajectory.
Additionally, by preventing or by treating hepatitis C virus, we were preventing further cases from occurring in our community. So that's the very important thing. These individuals that Wes goes out and sees are not able to attend office-based treatment. And so the likelihood of them continuing to spread HCV, since you would say the majority of them are currently people who inject drugs. So
or recently quit.
Yeah, so the likelihood of them spreading it is very high. So being able to prevent further spread is another really, really important part of what Wes does.
Excellent. We are public health too. I keep saying that. I will continue to say that. Before we go any further, we're just going to take a second and have a quick word from our sponsor.
Lexapol empowers first responders and public servants to best meet the needs of their residents safely and responsibly. Serving more than 2 million public safety and government professionals in over 8,000 agencies and municipalities, Lexapol offers a range of solutions that includes policies, training, behavioral health resources, news and analysis, and grant assistance services for law enforcement, fire and rescue, EMS, local government, and other agencies dedicated to public safety. To learn more, visit lexapol.com. That's LEXIPOL.com.
And we're back. That was the voice of Jim Dudley from Policing Matters. Do take a moment to go over to Police One and listen to Jim. He has some amazing guests talks about a range, not only of policing, but also of public safety topics. Don't forget also that we are on YouTube. We are on wherever you get your podcasts from, so you can either listen to us or you can see us. If you follow us on YouTube, we put slides, charts, graphs in. So this is the webinar you didn't know you needed. Talking to the folk from Prisma Health Mobile Integrated Health Team. And we were talking about some of the programs that they're running. We were talking about the importance of having an epidemiologist on staff and using in this case Dr. Mirinda Gormley to her fullest extent. But also there are other MIH community paramedic programs going on. And Parker, of course, you were doing the job that Wes has just described, but you now have a different and equally as an important role. So what are you up to?
Just recently, I moved into a more traditional community paramedic role where we're seeing patients in the home on a weekly basis, more or less, where we evaluate once they're discharged from the hospital, any barriers to care, medication management, social determinants of health. A lot of the patients that we wind up seeing are referred to us when home health is unable to see them, either due to insurance needs, locations, that sort of thing. So the patients are already at a disadvantage to reaching care, whether it be their location or their finances. And so through that, like Wes mentioned before, kind of building trust, they see a healthcare provider that's there for them. Good, bad, or indifferent, our office has been described as bulldogs, and it's more physician-facing than patient-facing when it comes to that, right? I've personal experience where a primary care doctor wanted to prescribe a very expensive medication to a patient. The patient was 0% compliant with it because it was too expensive. And through some strong conversations with the physician, we moved back to generics of, metformin, the metoprolol, the stuff that we can get for $3 at Walmart or Ingles, and was now 100% compliant on the medications that the physician was less apt to prescribe, right? So it's with experiences like that the patients regain some trust in the system, recognize that there are barriers to care, but we can navigate them. Primary to this role as what we'd call a standard community paramedic, I was serving as one of the ETS providers, where we were treating in place at nursing facilities, which is a very novel idea. Any paramedic that's worked on the ambulance, we all love the 3 o'clock in the morning abnormal lab values at the nursing facility. You get the line of, "This isn't my patient. I just clocked in. I don't know the last time I started a shift at 2:20 in the morning, but apparently that's a common thing," right? And so we go into these facilities, we build relationships with the physicians there. By happenstance, the physicians at these facilities that we work in are Prisma physicians, so the communication is direct. When I document in our charting software, they can see it and vice versa. And so when we go out and see these patients, even if I can't see the physician face to face while I'm there, I can read charts and see what has been going on historically. Peg tube replacements, trach care, treat in place model. We know that they're dealing with a urinary tract infection or a pneumonia. We can show up and administer antibiotics and start treatment there at the facility, and then be another pair of eyes that look at the patient and say, is this safe to treat here, or do we need to call an ambulance and send them to the hospital for a higher level of care? It is not uncommon for those calls, and sometimes it's simple, right? It can be a 5-minute visit to draw some labs and make sure that the vitals aren't too far gone. But there are times where I've spent an hour or 2 hours on scene with a single patient, treating and building up a treatment plan before we even release the patient back to the facility. We've also dabbled with alternative destinations, which we know was an attempt at one point, kind of moving towards ambulances doing that on a standard basis. But for us in our network, we were able to, I visited with a patient who did not want to go to the ER, was very vehement about not going to the ER. Through his history, I could have convinced him to go because he was not, ANO4, he was 2.5-ish. So on an ambulance, he definitely would have gone with me to the hospital. But through communicating with his physician there and our department heads, my evaluation as a paramedic, as a community paramedic, was enough to make the physician there at ease that no neurological deficits from his fall. And then we sent him for an outpatient CT scan and X-ray to make sure that his hip that was uncomfortable was not broken and that his head did not have any bleeds. And then he was back to the facility in 2 hours from the time I got on scene with him. So we're doing a lot of stuff in just that emergency technician and skilled nursing to dabble in these spaces where we've tried it, not we, but the royal we. EMS has tried this in the past, and because of payer mix and that sort of thing, we've just not been able to be successful. It takes systems kind of taking the hit sometimes to make this work.
So you've broken down in my entire checklist of what I think a good old-fashioned community paramedic should be doing. Obviously, everybody that's listening, everyone on this call has done the care home call, where perhaps the only solution is to take the patient to hospital because you don't have either the training or the protocol to actually treat them in place. You don't have the ability to negotiate with the care home. You don't have the bulldog effect or the diplomacy skills to deal with physicians. And it sounds like you've got that cracked. So what sort of extra add-on training and education did you have in order to to get this job and to do what you do now? So let me rephrase that. For those that are thinking about going down this particular MIH pathway, what do they need to be able to do?
So for our department, I started out as a paramedic. I came off the truck, and within 2 months, between onboarding and just getting my ride time in, I was released as a community paramedic. Right. Our own internal training department handled the hands-on for peg tube replacement, ISTAT bedside, lab evaluation, and ultrasound skills, right? We're not doing the fast exam to make sure that folks do or don't need surgery, but we are doing volume status, lung scans, and ultrasound guided IVs, just other stuff that we know would lead to high frequency, low acuity hospitalization. So all of that was done in-house. As far as what we require and what we've learned through the IBSC, the community paramedic training there was huge. And being able to take my time in wound care with physicians kind of on that peer-to-peer level where, hey, I'm going to be doing this in homes and in facilities. What do I need to know? Was a big part of our training that helped set up the foundation for being successful, and then being self-driven. It was very rare on the ambulance for me to need somebody else to look for answers, right? And that's not trying to be a braggart, but just problem solving was an innate nature for me as a paramedic, as it is for a lot of paramedics. And so walking into the facility with the mindset of I'm going to do everything in my scope of practice to keep you here was a big shift for me. One of my first patients at a facility had a blood pressure of 70/30. Ambulance side paramedic Parker would have probably thrown him in the back of the truck, lights and sirens to the hospital, grabbed the IO drill, where's my presser, right? Community paramedic Parker said, so how are you feeling today? What's your actual complaint? The son happened to be on scene, so he was on board with the plan and treat in place for an hour and a half before we decided that a bag of fluid was not enough to fix the problem and there was something else going on. Let's go to the hospital. But it wasn't this rush job of lack of information and poor planning. There was lots of planning involved, lots of discussion and care prior to that movement to the hospital.
Great, thank you. Luke, you've got an amazing team, my friend, and as you say, these people clearly have the heart for the job. And so I've heard what Wes and Parker are up to. I mean, what's next?
Well, yeah. So in addition to Wes and Parker, there's 16 other folks that are part of the team that aren't on this call, right? So they're doing amazing work as well. Next for us is, if I could circle back to Parker's training, is we're very fortunate, right? We're very fortunate to be part of a large healthcare system in the state of South Carolina that has a medical school, the University of South Carolina School of Medicine in Greenville. So for all of those skills, yes, we have clinical educators within the hospital. Yes, we have physician educators within the School of Medicine. Really, it was, hey, we'd like for you guys to do suprapubic catheters. And we'd say, okay. And we go to clinical education. They say, yeah, we got a class for that, And so we would just take the class. Next for our mobile integrated health, the biggest thing that we're focusing on now is during Helene, we took a pretty good shot here in upstate South Carolina and from Hurricane Helene. we demonstrated as a mobile integrated healthcare team, we demonstrated that medical sheltering needs for community paramedics was a need, and that we actually pulled it off, and it was a really good thing. We took our community paramedics for folks who had chronic disease processes, and we managed wound care, we managed oxygen therapy, we managed all the things that they would have at home, glucometer usage, food, nutrition. We managed it all at a state medical shelter. So now we're in talks with the state of South Carolina on how mobile integrated health can be utilized during a medical needs sheltering medical needs sheltering. We are in conversations with the South Carolina EMS Association about mobilizing community paramedic strike teams that can be called up and go into a situation in which another agency within South Carolina feels like that they could use some community paramedic needs. We're trying to type community paramedics in the FEMA resource type. So we're going to have, we are currently not typed in FEMA resource typing tools. And so we are trying to establish a typing tool, hopefully through the state of South Carolina, which then FEMA will adopt. So, there's a lot, but when you have folks that are passionate like this, and this is two of them, right? We could talk all day to the other 16 of them, and we'd have amazing stories.
Well, first of all, I think you need to be writing all this up in a non-academic sense. I'm going to come to you again, Mirinda, in a second. But obviously, the practices that you are delivering is worthy of articles and indeed a longer form webinar on any of the topics that we've just been talking about today. Let me start by saying that because I think you're doing some amazing stuff. Of course, we started with the data. It set out the need. You established the program. You delivered the goods. And of course, the thing that Parker said to me, Mirinda, is HIE. You've actually got the ability to reach back into the hospital to actually get the information that you need. But now that this is now churning away and you're getting more and more results every day, what academically next are you looking at producing with the stuff that you're learning?
We already did an effectiveness study on our HCV iLink program, which we published in Open Forum of Infectious Diseases. We started with the case series, of course, where 3 patients that were very hard to link to treatment. We wrote that up first, published that, and then we went into the effectiveness study. We have since, I believe, by the time that study was published, I believe we had cured about 39, 40 people, but you have now cured close to 60?
Close to 70.
Close to 70 people. So, and that's you have to remember he is the only one that does that program. So that's just him going out 1 or 2 days a week to see those patients, which is a huge deal in a rural population. So what we're going to do next is we would really like to show people how you can start this model in your area. We are very lucky at Prisma Health because we have funding from Focus that helps us identify HCV in our emergency department. So for example, if you come to my ED, you sign a consent form. On that consent form, it says that you will be tested for HIV or HCV unless you opt out. If you do not opt out and you have not been tested in the last year, we will test you. And one of the things that we realized when we started doing that in our ED is that there is an epidemic of hepatitis C virus. And whereas we are able to link 2 out of 3 of those people to treatment from the ED, that 1/3 of individuals who were unlinked, we are now catching with our community paramedic program. So one of the nice things about our program is that it's hospital-based, right? One Prisma Health. We have Prisma Health Ambulance Services and the MIH program and us. So one of the things that we're trying to investigate is we have now started collaborating with Greenville County EMS. They are participating in the CP-HCV iLink program, and we want to do a process evaluation to look at the different things like what are the barriers to implementing this? How have we adapted our protocol to address some of those barriers? Early on, there was a huge problem trying to connect patients to the infectious disease doctor because they live in the middle of nowhere and no internet signal hits there. So we had to adapt the trucks to adjust for that. We have had to adapt our process for getting medications, and we've had to adapt our protocol for dealing with individuals who are unstably housed. So all of these things could be written up more or less as a guide map for anybody else in the United States who would like to adopt this model. So that's our next step for that program. We'd like to do something similar for the buprenorphine program. Right now, our buprenorphine program is on hold because the state of South Carolina has asked us to stop buprenorphine until they can do a little more investigation. But once we get that going again, we would like to do a similar evaluation of that program, again, providing a roadmap. When I told you about our scoping review, we found that a lot of the models that are in the United States are not only urban, they also use one delivery or the other. Either they use community paramedics or they use 911. We use both. And we have found that having both is really the most effective way, in our opinion, to connect people. So we would really like to write up our model and a bigger investigation on how other people might be able to implement that model in their areas. And then finally, Luke can speak to this because I have not been involved in the evaluation of the ETS program, but I know that Luke is working really hard to do a thorough evaluation of the ETS program where we take our community paramedics and they worked in the skilled nursing facilities. That's a very novel program. I've never seen any published research on a program like that, and we don't know of very many other programs that do something like that. So it would be wonderful if he could write that up. So again, other people could use that as a roadmap of here is a way that you can increase the quality of care and decrease, unnecessary admissions to the ED.
So when I asked you to come on, I knew you all had a story to tell. So Luke, you've got your writing orders from Dr. Gormley there. But as we finish, though, I'd really like you to kind of bring us home in terms of, talk about your team, talk about the results they're achieving, and then really sort of, encourage others if you want to get involved in all of this stuff. We have an outbreak of community paramedicine and mobile integrated healthcare in the US, but not as much, particularly in rural areas. So over to you.
Oh, appreciate it. Yeah. So, like I said, having an amazing team makes this a very easy process for me. You find where your team has passion and you put them into the right spot so that they can just take off and run with it. We use a lot with the right patient, the right resource at the right time, right? That's a lot of rights. Right resource, right patient.
But it all sounds
time.
right.
Right. So basically just saying, identify what the patient needs. If that patient is in addictive medicine, then we're going to send Wes because Wes is passionate about addiction medicine. If that patient is in unhoused, we're going to send Parker because Parker's a passionate about unhoused patients or unhomed patients. So it makes it really easy to do something like this. But it also makes the support of the healthcare system, the support of our medical control, all of that is important. And we're happy to talk to whoever. I don't know about writing anything. I'm an old paramedic, right? I do things. I break things. So I don't have the mind to write anything, but I think, yes, we should really talk about how our programs have changed kind of healthcare and the way healthcare is delivered. And we understand that the way that we were doing it wasn't working. And this is a new pathway to say paramedics can affect the way healthcare gets delivered.
Wonderful. What a beautiful summary. And if you would like to have your own Mirinda, Wes and Parker, then listen to this. Also, we'll put you in touch with Luke. This was just the tip of an amazing iceberg that Prisma is delivering in South Carolina. And I knew it was a good idea to have them on really to give us an appetizer for some of the things that they're doing in order to inspire you to go away and do it in your system. You may not have an epidemiologist on staff, but actually I'm sure that through public health, you can probably get access to one. There are always opportunities. There's lots of EMS research outlets going on that you can get involved with if you want to come up with a project and a program and a paper in order to drive action. So have a think about that too. So for the minute, I would like to thank my guests from Prisma Health. It's really been a real pleasure. And I hope we can come back and do a deeper dive into some of these areas in the future, guys.
Absolutely.
Absolutely.
Great. Well, that was another edition of EMS One-Stop. As I always say, please make sure that you like and subscribe wherever you get your podcast from. Please make sure that you tune in to see us on YouTube. Give us the maximum amount of stars possible. My thanks again to the team from Prisma Health in South Carolina, doing some amazing stuff. That's it for now. I've been Rob Lawrence. This was EMS One-Stop. And until next time, bye for now.